My name is Martha Halko, and I'm the Partnership Coordinator for HIP-Cuyahoga from the Cuyahoga County Board of Health. We have been working collectively for several years now for this culminating day. The Cuyahoga County Board of Health is the backbone organization for HIP-Cuyahoga, and what that means is that we basically maintain the day-to-day operations of the partnership as it has grown to well over 100 partners and individuals and organizations that are actively involved. And as an agency, we provide strategic vision and guidance to the process. We provide support for communications and evaluation and measurement with a wonderful team of individuals and organizations. I'd really like to welcome everyone this morning to our event. Many of you may have been surprised to have been part of HIP-Cuyahoga to see a 1-hour event. We're usually a full day and have been multiple days, so I know folks had blocked like their whole day, and they're like, "You're only an hour?" I said, "Yes, only an hour today." But this is a really wonderful culminating event for us. It's both a celebration and a kickoff for several years of work where a wonderful team of individuals and partners have worked together to gather input from the community and engage the community in this planning process, strategic planning, data collection, and really shared insights by a wonderful host of partners. For those of you who are new, and actually I'm going to, just to try to get a sense of who is new, we're going to talk a little bit about who HIP-Cuyahoga is and what we do. But if I could just see a show of hands of who is brand new in the room for HIP-Cuyahoga for an event. Wonderful, wonderful, welcome. And we're going to hope that you join us moving forward. The Health Improvement Partnership Cuyahoga, as I mentioned, is a wonderful diverse group of organizations and individuals, and really we've come together to work to develop a plan that provides opportunities for everyone in our county to be healthy. We really believe as a partnership that all people in Cuyahoga County have the right to live their healthiest lives, no matter where they live or work, how much money they make, or what their race, religion, sexual orientation, or political beliefs. We were convened in 2009 as a planning committee to develop really our county's first ever community health improvement plan. And really we came together to guide our community in addressing some of the most pressing health issues impacting the health of our county's residents. And you'll really hear today how this plan is different. It's different for public health, and it's different for many of the partners that we've brought around the table. The work of the partnership and the development of this plan was really a testament to true partnership and coordination through the generous support of so many of our partners spending countless hours having multiple staff engaged in the process, their organizations deeply invested, sharing their staff, their resources, their knowledge, and their experience. And really also very, very important to this process was the generous support of our partners and our local foundations. St. Luke's Foundation, Mount Sinai Healthcare Foundation, and Gun Foundation have really, really rooted themselves in this process actively beyond just providing resources, which has been really, really important to our work, as well as contributions from the National Association of County and City Health Officials, as well as the Centers for Disease Control in our ability to begin to implement our work as well. What's exciting is that the group has continued to grow and is now a thriving consortium with shared visions, shared values, and shared goals. We hope that many of you that are new in the room today will join our movement to improve the health and well-being of all who live, work, learn, and play here in Cuyahoga County. So I'd like to share a quote because I want to be able to pass this on to our panel, our wonderful colleagues from the steering committee. But I wanted to share a quote by the great Dr. Martin Luther King Jr. that really encapsulates for me why this partnership is so important. Human progress is neither automatic nor inevitable. Every step toward the goal of justice requires sacrifice, suffering, and struggle. The timeless exertions and passionate concern of dedicated individuals, which is who we've had guiding this work, and which is who we have in the room today. So before I transition, I want to ask all of you to refer to the Twitter information on your tables, and please share your thoughts and your comments through Twitter. And you also have note cards on your table. We will have probably a shorter time than we would desire to have you all ask questions in the short program that we have. So we would like to ask that you generate questions on the note cards. We will collect those and actually answer those questions and post them to the website for everybody to be able to access at a later point in time. So now I'd like to turn it over to Kay Colby. We are so grateful to have Kay Colby working with us. She's a 6-time Emmy Award-winning producer at WVIZ PBS and 90.3 WCPN Idea Stream. She will moderate our discussion today on the collective work of HIP-Cuyahoga to address some of the most pressing issues impacting the health of our county's residents. Thank you.
Well, thanks, Martha. And I am excited, very excited, to be part of this morning's event to kick off Cuyahoga County's first health improvement plan, because many of the issues inside this 55-page document are really near and dear to my heart. Full disclosure, before I joined IdeaStream, I spent 10 years as an NIH-funded researcher working with low-income families in our Hispanic and African-American communities to understand the barriers they face to achieving optimal health. And some of the situations I saw were heartbreaking. So I am all about trying to propel dialogue and projects to confront these issues. And I hope we're going to have a very provocative and deep discussion today. So that being said, this 55-page document is divided into 4 focus areas, and our panel members all represent the different subcommittees, those 4 focus areas. So I want to introduce Greg Brown. You are representing the subcommittee on eliminating structural racism. Then we have Dr. Heidi Gullett, and you are representing the subcommittee on kind of bridging the gap, improving coordination between public health and our clinical care organizations, mainly our large hospital systems. Welcome. Then we have Erica Trappel, and you are with the Healthy Eating, Active Living. I love the acronym HEAL. Diet and Exercise. Welcome. Then we have Rita Horwitz, and you are representing the subcommittee on managing chronic disease. And we have Terry Allen, Health Commissioner for the Cuyahoga County Board of Health. So I want to start out with what I consider a pretty sad fact. In 2003, the Institute of Medicine unleashed a report. It was called Unequal Treatment, about health disparities in America. Here we are, more than a decade later, we haven't moved the needle. So I want to know, how is the plan and the approach going to be different? How are we going to move that needle?
We're very polite in the Midwest. I think that in a general sense, Kay, the way we want to move the needle is by addressing not just fundamentally issues related to health, but also those conditions that lead to either good health or the lack of good health. And through that, we get into issues such as challenges and barriers as it relates to structural racism. We get into issues around coordination between public health and what we call clinical health entities, so that we better understand the issues and address those issues directly. When we talk about managing chronic diseases, the topic of vascular disease and the resulting high blood pressure issue is one that's prevalent in our community. That's being addressed by Rita's subgroup. And then when we talk about healthy eating and active living, Erica's group, we're talking about not just access to high quality food, but affordability of that food, bringing people closer to that food, educating them about the need to eat better, and then the coordination of physical activity, because we all could use more physical activity. So I think we have pragmatic steps that we're taking, pragmatic kinds of activities that we're engaged in that we think will not only move the needle but cause a change in the way that we go about addressing these kinds of issues.
And I know, Terry, you've talked about it as a true paradigm shift. We're not looking so much at individual responsibility and individual behavior, but what are these social and economic conditions that are a systemic analysis, so to speak, that are keeping people from engaging in healthy behavior? Could you kind of elaborate on that?
Sure. First, I wanted to, our first speaker was Martha Halco, and Michelle Shaw, working closely with her, have been integral to the success of this work, keeping us on the straight and narrow, and I wanted to thank them both for that work. They've done a hell of a job. So there's a guy by the name of David Kindig, who some may know as the father of population health, really responsible for the early formation of the Wisconsin health rankings. And you know where we sit here, those have seen the data. We are usually in the bottom third of counties in Ohio, and we certainly know that we have great clinical care. Everybody knows that and appreciates that and is very happy with that. But we don't do so well on overall health and certainly on some of the issues around social determinants and the environmental factors, and that's why we're here. What David Kindig tells us is that he has looked at maps for decades showing chronic disease, looking at late-stage cancer diagnosis and then higher rates of mortality that exist in African-American populations, higher rates of high blood pressure, asthma among pediatric patients. These data have not changed for decades. And so for me, it's a real perspective transformation. We're on track, looking at, and based on some United Health Agency's data, for half the country being diabetic or pre-diabetic at a cost of $3.5 trillion. That is not sustainable. We need to do business differently. The perspective needs to change. So we need to look at what creates health. What are the resources that create health in the community? And where are there places where those resources exist, and where are there places where they do not? And how can we, in a very meaningful way, begin to think about how we use our resources, ensure that everybody has the same opportunity to be healthy. And that doesn't currently exist. And it's unacceptable that these maps continue to look the way they do, and for us to say, well, I mean, what is the answer? Say that's a shame? That's not acceptable. It means that we have to change the way that we do business, and I think that that's what this is about here today.
And it really is changing the narrative. Again, instead of blaming an individual for not exercising, maybe looking at the social and economic circumstances that act as barriers to keep them from exercising. Erica, you want to comment on that?
Yes, so that's part of what we're thinking about and looking at in our Healthy Eating and Active Living subcommittee. And we're really thinking about two different strategies to improve the physical environment and the opportunities that exist in neighborhoods. One is really advocating for complete and green streets, and there's some great work happening right now around that. And the second is to, so the complete and green streets really just changes the actual roadways, bikeways, and walking ways so that naturally becomes part of the environment. No individual has to do anything. They walk out of their door and they have opportunities for safe physical activity. The second approach is to increasing and utilizing the resources that we already have in our communities, the assets, the physical assets, to provide spaces for programming that neighborhood residents want to engage in.
And one of the other things that strikes me about the plan, I feel like it's a culmination of cross-pollination, in that we're asking people to get out of their individual silos. Everyone's kind of done their own little thing with grant money, and it's kind of a shotgun approach to fixing things here and there. Tell me how this is more coordinated.
So one of the things that we've very intentionally done during the last few years is engage the community and our neighbors in understanding what really matters to them. So that's really key in this, because in the past sometimes we've worked in isolation in public health or in clinical medicine or in community organizations, and we haven't always necessarily had the perspective of the people impacted most. But we also have come up with programming. Even if we did have some of those perspectives, we've come up with programming, or we've worked really in isolation. And this is pretty pronounced specifically when you look at public health and clinical care organizations. And so one of the things I quickly realized very early in my practice career as a physician is that I couldn't help people become healthier because in many ways, because the reasons that they were unhealthy were the things that were outside of the walls of the clinic. And I could continue to prescribe more medication and tell them what control they needed for blood pressure or diabetes. But it was very difficult for me to figure out how to practically address poverty or practically address the structural racism issues that have created barriers to them having healthy places to eat and places to get affordable, healthy food. And so this particular approach is that we are really in a genuine, unique dialogue, I think, about what the strengths each of our organizations and each of our perspectives brings. And for me, in clinical medicine, we can't do this alone. We have world-class clinical care, but we know that the disparities in our community continue to persist despite advances in medical care. And so this, to me, is a very honest, genuine discussion about what can we do to implement best practices on the clinical side, but what can we do at the same time to impact structural issues that are creating the reasons that we have high rates of cancer deaths and we have high rates of high blood pressure.
So I want to move on and spend probably about 15 minutes talking about kind of what is a reoccurring theme, an underlying theme of this plan, and that is eliminating structural racism. And I want to start off reading a quote because I think this will kind of be a springboard. It's from Professor Warnie Reed. He's the Director of Race and Social Policy at Virginia Tech. And this is his quote: "Race determines how long and how well you live in this country. Race is a matter of life and death." So I kind of want to have one of you take it from there.
Okay, I'll start. And knowing Dr. Reed from his association here at Cleveland State University's Levin College, I know that Warnie was very sincere and has done years of research and did not make that statement without a very scholarly approach to understanding the analysis of data. And one of the things I want to talk about that's kind of embedded in what Dr. Reed was talking about is the idea of intentionality. And the idea when we talk about structural racism that we're really not talking about individual prejudice or bias, but we're talking about the systems and structures and how they historically have been organized, how resources have been apportioned, and who has received them, and how some people have been advantaged as a result of that, and other populations have been disadvantaged as a result of that, thereby just really creating disparities, not just because individuals are incapable or don't have the wherewithal to do something, but because they are fighting against inherent structures and systems that make it more difficult and more challenging for them to succeed. The other thing is this intentional idea. You know, we're not calling people racist. That's not embedded in this idea. But what is embedded in this idea is that there have been practices and policies created historically in this country that have led to systems and structures that do act unconsciously and in some ways consciously to disadvantage people, especially if they're people of color or ethnicity. And I just believe that if you are driven by the value proposition that all people should have a chance to live the optimal quality of life that they are able to obtain, then in fact, we as Americans have to ensure that everyone, not just some, but everyone has that opportunity.
And I think, Terry, you want to chime in. I can tell the whole historical practice of redlining with the housing policies, federal housing policies, and how that corresponds to these outcomes in maps now that you have with poverty and other infant mortality, lead poisoning. Can you elaborate about how the data is really supporting this argument for addressing structural racism?
Sure. So you know, by the way, we all pay for poor health in terms of the cost to the system and health outcomes. And it's important to think about, as we think about the greater Cleveland community, and I think given where the Cavs are at, we couldn't be more united in our views. And we need to think about that as a community, no matter where you live, that we need to think differently about that. and we think about the workforce and the economic opportunity and success of the region, it has to be a collective view. So our work on Chris Kippis, our Director of Epidemiology, Surveillance, and Informatics, along with colleagues, looked at the redlining maps, and that's the data that if some are not familiar, looking at the historical practices that go back 60 years or more on making decisions about where loans would be given out, favorable loans, on where people could live. And the data is astounding. There was a City Club presentation talking about the data presented by the Kirwan Institute from the Ohio State University. And so looking at that data really increased the likelihood that some would have opportunity to purchase a house, and also in terms of the trajectory for quality of life and opportunities for employment and the like. Some folks had opportunities and others didn't, and those were divided along racial lines. And if you begin to layer over the chronic disease data that we talked about, and if you look at life expectancy data, there are communities here where there's 20 years difference in life expectancy that exists, and they're only miles apart. And that ain't right in America. That should not be in America. And if we begin to look at the diabetes data and the cancer rates and related data, you begin to layer this information. It is undeniable that race is a huge factor, and that, frankly, we know, and it's been said, it's become sort of, I think, importantly, common knowledge to people, that your zip code is more important than your genetic code at dictating how healthy you will be and how long you will live. And unless we decide across clinical medicine, public health, the nonprofit networks here, the faith community, the media, until we decide that we want to begin demanding, frankly, that we look at what creates health and assuring that in America, everyone should have that same shot at being healthy. Until that happens, and I think we want it to begin happening now. If it doesn't begin to happen, to me, the crowd that's here is indicative of how important this issue is. And everybody up here and everybody that's been part of this process is very passionate about it. And it's time to talk about it that way, or it's not going to change.
So you just brought up a really important point, and that is being bold enough to go there. I got to tell you, when I wrote in 1998 my first health disparities grant, I was told you cannot use the word racism. You will not be funded. Now, 2015, you guys are going there. You have it as one of your key priority areas. What's different now that's telling you it's time to go there?
Well, I can speak from the Chronic Disease Subcommittee, and when you think about how we are, in fact, moving the needle on the care that we deliver and reducing disparities. We've seen progress. The Better Health Partnership works with primary care providers from all across the region to change the way we deliver care in our health systems and pay for that care. And we have found best practices so that we can make sure people have equitable care. We have reduced the gaps in that care with diabetes eye examinations, pneumococcal vaccines, to make sure that everybody is in fact getting those the same, whereas before there was as much as 10 to 20% differences between whites, Hispanics, and African Americans. We've reduced that. But the problem is we have not yet reduced that same gap in outcomes. So when you think about blood pressure control and you think about high blood pressure control and glucose control, those haven't been changing much. So we have to look at, again, how are we going to address that? We've got to get to the social determinants of health. We've got to connect that great care that's going on to, in fact, the healthy eating, active living, and the other kinds of things that we've been talking about.
And Rita, you have data about blood pressure control and how it correlates with the resources available to certain demographic groups about how well they can control their blood pressure based on the resources they have. Tell us a little bit about that.
Yeah, so our group is looking closely at what Kaiser did in California, which was published in JAMA in 2013, and they actually, by implementing some very, very pragmatic, simple kinds of things and working with providers, to look at clinical protocols, look at medications, trying to make them more affordable for people, going to sort of once-a-day dosing of medications versus multiple, how to take a blood pressure, when to take a blood pressure, how to reach out to people to get them back in to control that blood pressure. Kaiser actually shows that they were able to move from 44% good control to 80% good blood pressure control. That's a huge jump in all populations. We are leveraging that best practice. We are bringing it to Northeast Ohio, and we are, in fact, deploying those best practices in 9 different clinics and 5 different health systems as part of this work.
As part of the plan.
Yes.
So I want to know, how controversial has it been to have eliminating structural racism as one of your focus areas? Have you gotten pushback?
Excuse me. Okay. Don't want to get you tied up there. I would say that being very modest, the answer is, yeah, okay. I mean, we are a society that is uncomfortable talking about race in any form. And before I go on a little farther, you know, this is not just an issue of Cuyahoga County. This is a national issue. And I'm fortunate to be a member of the Cuyahoga Place Matters team, which is a part of a national collaborative that is working under the National Collaborative for Health Equity, working in 16 cities across America, which is really looking at the issue of health equity in a way of trying to not only think about how we do things differently from the perspective of not just individual health but population health, but also to address these issues of structural racism and bias and those kind of things, because they undergird a lot of who we are culturally. And for many of us, it's an uncomfortable kind of thing to think about, because none of us want to see ourselves as being prejudiced. But in fact, we all are. We all discriminate. We all do. Some of us do it based on race. Some of us do it based on the clothes that we wear or the people we associate with. So, I mean, it's inherent in who we are. The issue is, though, should we be using that as a way to govern, develop policies that impact people's life chances, not only just to be healthy, but to have a great quality of life, to have a good quality education, to have access to employment to support their families, to not live in areas that are environmentally unsafe. So as Terry was saying, you know, this is unacceptable in America. And America traditionally has always held itself out as the land of opportunity, when in fact, we have to challenge ourselves to provide that opportunity for everybody that is an American, and we haven't done that. The other thing I would say about the pushback is that it's always part of our institutional structures to not want to go there, because they're basically conservative. And I don't mean that in a negative sense, and I don't mean it in a political sense. I mean that most institutions, studying bureaucracies, are not necessarily given to the idea of change, especially change when it means that they have to think differently to act differently. So, in my opinion, we have a lot of work to do, but the work starts as a movement organized around this plan with the people in this room building that and working with citizens and people in organizations and elected officials, and to continue to move that. But we got to get at this issue about the sensitivity to talking about race in this country and not feel that we are talking about you as an individual, because we're not. We're talking about us as Americans.
I like that you brought up the intent, because it was so clear. I think it was on Sound of Ideas earlier in the week. You all brought up, it's not, the intent doesn't matter. What matters is what is in terms of policies and structures. And that was so clear to me. That made a lot of sense, because it takes the onus off thinking, oh gosh, am I prejudiced? Do I have, you know, discriminatory thoughts, that kind of thing. But I gotta say, you are getting some pushback. Not everybody is all in on this one. right?
Not nearly.
So how are you posed to meet the challenge of people saying, you know what, racism is such a politically and emotionally charged term, I'm going to tune out and I'm not going to go there. How are you all going to get people to go there?
So we did a lot of internal sort of soul searching about why we're really part of this movement. And that was a really important process because you can't talk to people about what they think or whether they are willing to join us in this movement if you don't understand why you're a part of that. And so Greg and I really have reflected a lot on why personally this matters to us. And I think when you reflect on story and you can communicate effectively why it matters to you and why in this community where you're born and raised or whether you're transplanted here, we'll still call you a Buckeye, it's okay. It matters to us personally, and I think one of the ways to break down some of the barriers that come in between us as individuals and our organizations is to understand that we're personally committed to this and we're professionally committed to this. And when you can articulate the value for you personally as well as professionally, there begins to be an opportunity to have a shift of perspective. With your colleagues, with your organizations. And many of us think that same way, but we don't necessarily have opportunities to talk about it with one another in our regular daily work. So I think one of our strategies has been to understand ourselves, what matters, why does this matter to us, so that we can articulate that to other people and then begin to have honest dialogue with our colleagues, both in our own organizations and outside. Because organizational change and organizational behavior is a tough thing. And in order for perspective transformation to change an organization, it starts with individuals who really care about the particular issue or movement. So that's one of the things that we've done internally that I think is really powerful. One of the ways to understand whether you actually know what you're talking about is to try to teach it. And I've learned that at the medical school, because if you start talking to the medical students about something and you're not 120% sure you know what you're talking about, they will figure it out quickly. And they will ask you questions that make you realize you need to figure a different way to teach it. So one of the real wonderful pieces of being involved in HIP-Cuyahoga is that our colleagues, many of those here in the room, have come and taught our medical students over the last few years about health equity. And I've realized that that's a hard concept sometimes to teach, but Terry has asked me to use a metaphor that I sometimes use with groups. So we have equality and we have equity, and I think we're used to equality. We're used to sort of making sure everybody has the same, everybody's got something. But that's very different than equity. Equity is really thinking about what specifically is needed in a group or an organization or an individual and meeting that need, meeting people where they're at. And so if I came in here and did Oprah's a few of her favorite things and said, hey, today's the day, we're giving away free shoes, check under your chair. Don't really, because we don't have anything for you. But if you did check under your chair, you would all have a pair of size 7 pumps. And Terry didn't know what that meant, so that means high heels. Thank you. He said, pumps, what are those? I said, you don't wear pumps, it's okay, they're high heels. Okay, but in all seriousness, how many of you could really wear a pair of size 7 high heels? It probably wouldn't be your first choice in shoe, or might not fit, or might not be the shoe you need. But if I came in here and I talked to each of you and I said, what kind of shoe do you need for what you need to get done in your day? And what size do you wear? And what is the width of your foot? And then I ensured that each of you under your chair had that shoe that you needed at this time in the right size. That's equity. And that's the way I often explain it to learners who haven't ever heard of this topic. And that, to me, is about perspective transformation. It starts with an awareness and moves on a continuum to movement and change.
So we need to move on now. I thought that was an excellent definition of that whole perspective transformation, because that's kind of an abstract concept. And I want to get into some more tangible things in the plan so people come away with some concrete things we're going to do here. So let's start with Rita. You're the anchor of the Managing Chronic Disease. So tell us, you're really going to attack the blood pressure problem in certain ways. What are some tangible kind of milestones we're going to see from that part of the plan in the next couple of years?
Absolutely. So we're going to start today. So probably 1 in 3 of you in this room has high blood pressure, according to the statistics we know. So if you're watching the Cavs game tonight, please be sure to take your blood pressure medication. the first item. So, in addition to that, though, we absolutely have some very technical kinds of approaches. And one is we spoke about the Kaiser best practices. So we're bringing that here to Northeast Ohio. We will work to train providers on those best practices. We're bringing in cultural competency training, so much what Heidi just described with the pumps. Physicians, providers need to learn how to do that. I can't just write you a prescription for your medication and send you out the door and expect that your blood pressure is going to be controlled. What is going on in your homes? What's going on in your workplaces? I need to take the time to understand that. I need to understand unique needs and challenges of various populations, minority populations, and I need to adjust the type of care that you need to get, and I need to leverage my whole team of people, my care coordinators, my navigators. Maybe we'll get to community health workers at some point that can actually help those people take what the physicians say I need to do and actually do it. We're also going to promote much more self-management and self-activation through chronic disease self-management programs that our Fair Hill Partners is working with us on that. And that's going to involve everybody in the community. We need people, we need community residents to get involved in those programs, to become trainers, so we can hold these sessions in your churches, in your neighborhoods, and get people involved in taking care of themselves. Do they even know how to do that? Do they know how to monitor their blood pressure? Can they be a support group for one another? So we are actively moving in that direction as well. And we're working closely with Erica as well in terms of connecting people to healthy eating and more active living kinds of resources in the community.
So that brings us to Erica. Tell us what is going to go on in the healthy eating, active living component of the plan.
Sure, we have three goals that we think we'll be able to accomplish over the next couple of years. With regard to healthy eating, we'll be really launching our healthy retail work, which will include expanding the number of stores that have healthy offerings, fresh produce, but other healthy things that might not be in some of those smaller stores right now, that builds upon the great work that's happening in Tremont with the Tremont West Development Corporation and their Corner Store initiative. And it also involves a number of partners in thinking, how do we layer on to encourage folks to go to those stores and think about the other ways to get healthy foods into the neighborhood. I talked earlier about the shared use policy, so we'll be really doing a lot of training work to train organizations about how to develop shared use policies, how to share their space with other organizations, and how other programs can seek out shared use sites to bring their programs to neighborhoods where they're desired. Then lastly, we'll continue to work towards development and implementation of complete and green streets. The complete and green streets policy has been passed in Cleveland, I believe, in 2012, and the Cuyahoga County Planning Commission developed a great toolkit about 6 months ago that they will be taking around to other municipalities in the county to really encourage more of that kind of work.
All right, great. Heidi, one thing I continually cannot wrap my mind around is we have some of the finest medical institutions in the world here in Cuyahoga County. The Cleveland Clinic, UH Metro Health. Yet we have some of the most poor outcomes, health outcomes, in the very backyards of these institutions. So what is the plan going to do to connect the disconnect, so to speak?
So it's sometimes really difficult to think about the work that you do and that I might be impacting just one person at a clinical visit, and yet, wow, that's just one person, and all of the other outcomes that we see for the thousands of other residents are unacceptable. So we really have been looking carefully at what are the practical steps we can do to make this happen. And so we have both a high 30,000-foot view goal, and then we have a sort of on the ground. So on the ground, we really want to demonstrate how collaboration between a community partner, the Board of Health, and our clinical partners can happen. And we decided to do that around asthma. They could have chosen a number of topics, but we have a lot of clinical expertise and public health expertise around environmental conditions that impact asthma outcomes. So one of the ways in which we're doing that is partnering with Environmental Health Watch, who's a co-anchor, and who was just awarded an amazing grant to move this work forward on Tuesday, so congratulations to them. But we're using their work and the work of the County Board of Health in environmental home assessments, and we're creating that as part of the medical plan of care. Because in medical plan of care, we often discharge people from the hospital. Here's your medication, here's your asthma action plan. When you're having this peak flow, then do this and call us. But the problem is there are pest issues in the home. There are problems with the roof. There are problems that need fixed in that home. And so we know public health and our Environmental Health Watch partners know how to do that. So trying to show in a demonstration that that's a medical plan of care that's a key partnership, and then that it gets paid for. In the usual way, we pay for regular medical care. So having insurance reimbursement to do that. And that's the work built on by Dr. Dora Dearborn and others. And I just want to say that that's an exciting sort of on the ground part. But the other piece of this is, this community health improvement plan came out of a comprehensive community health assessment. Public health departments need to do community health assessments. That's important, and that generated this CHIP that we're here today to talk about. But hospitals also have to do community health needs assessments, and those have traditionally been done in isolation. And what we know is that our priorities are sometimes different, but we're all in this together, and we're really all in this to make people healthier. And as reimbursement changes and hospitals change how they get funded, it's critically important that we start turning from focusing on interventive disease care, which is still important, but we start thinking a little bit further upstream about, wow, if we can prevent people from coming back in, we prevent them from even getting cancer to begin with, that's where it's really important. So a big picture way to do that is to align how those assessments are done for health departments and hospitals, that when the assessments are done, they're done together on the same timeline with the same interests, and with the same sort of data collection. So that's our other big picture piece here, and that involves a huge amount because they're on different cycles, different requirements, but we're committed, and we have partners, many in this room, who are committed to making that happen. So it's two different levels of approach.
And so we're going to wrap up with Greg. Eliminating structural racism sounds very idealistic and pie in the sky. What are some of the tangible things we're going to see in this plan towards that in the next couple of years?
Okay, we really believe that we can have this done tomorrow, so pie in the sky, I'm not sure, but I do want to talk about one consistent thing that you've heard here before I get into my comments, and I do want to say thank you to all the people who are on the Eliminating Structural Racism subcommittee who are here today and have participated in our work. One of the consistent things you've heard here is thinking differently to do differently. And we kind of say that as a quick definition for perspective transformation, and part of what we're doing in eliminating structural racism is really working on that ideal, which is we are trying to work, first of all, within our membership to identify people who are leading, supporting, or following in the health equity frame. And to that end, we are in the process of developing a readiness assessment to ascertain individual members' perspective on that right. And then we'll move from that to the organizations that many of the members represent. And then we'll move to the community itself and start to look at specific, tangible relationships and organizations that we see as strategic that we will also address through that. And once again, using the readiness assessment as an introductory tool to start the discussions, start to introduce the idea that we must change our systems and structures to better accommodate the outcomes we want to see. Part of our job is also to reach out to the media and figure out how to use the work that we're doing and communicate more effectively so people can understand that structural racism exists, and that if we don't try to remediate and ultimately eliminate it, then we will not ever see the kind of outcomes that we all say we want to see. So I always say that you can want change, but to get change, you must change. And that's what we're trying to do here.
So I think that's a great way to wrap it up. And we want to save time for questions from the audience. I think in the essence of time, it would be easiest if you just raise your hand and direct your question to the panel member that you want to answer it.
My name is Patricia Russo. My husband is Judge Anthony Russo. He appoints to the Cleveland Metro Parks Board. When he took over the position, it was a high interest to him to make sure that the parks were available to everyone and to develop them fully. As a registered nurse, we see our public-private partnership for public health. How can the Metro Parks help you all in working on this issue?
The Metro Parks are already a partner in HIP-Cuyahoga. I'm very happy to say that, and have been a very active partner, and have been great in identifying ways that they can be a partner without anyone else having to ask, and have thought of very creative ways. I know they're very involved in thinking about how to connect bikeway paths through the Midway project, and continue to think of new ways that they can contribute to making change and support this plan.
Good morning. Ann Hill from Metro Health. So the school system is in the process of deciding what schools to tear down, which ones to remodel, which ones to eliminate, and so forth. And one of the decisions they're faced with is at Lincoln West. And they have different scenarios. They're faced with some limitations in that the state will not pay for building or renovating gymnasiums, auditoriums, or pools. And at Lincoln West, there's a beautiful pool and a beautiful gymnasium, which are very much in use. But the school system is faced with potentially, one of the options is tearing them down. In my mind, this would be criminal for our community to tear down these major assets on the near west side, low-income community where there are not other assets like them. So to me, this is a concrete issue of both policy changes that are needed at the state around what they will pay for when it comes to school buildings, as well as a question for the community and whether the community will rally to help save this pool and this gymnasium. So I'm wondering what HIPC can do to help prevent the tear down of these really critical assets.
Thanks, Ann. And by the way, we're happy with the clinical work that Metro is doing in the school system, so we think that's fantastic and a great place for public health to link in. I see Tony here as well, and I know this is probably Tony Perla from the Cleveland Department of Public Health, probably big in her mind. I think that the connection between what creates health and people having access to what creates healthy is important. And I think we need to, through the work of HIPC, through the work of public health, through the network, to make it known to the decision makers that that's important. Where else will the kids go? I think we have to use it as a pipeline. Part of what we're doing going forward, and I know we'll talk about this, is that from a community engagement standpoint, we're building a plan around community engagement in a larger context to address the discussions that Greg brought up, the fact that we have funding through the racial and ethnic approaches to community health to actually accelerate and operationalize this work, that we should use those networks as a way to galvanize around issues such as what you've described. I think this is, by the way, the redlining maps go back 60 years. This isn't going to change overnight, and we're not going to unwind this overnight. This is not a sprint. We're going to be at this for a while, but the diligence and this perspective transformation is really, I think, what we're beginning today.
I would also just add that that is something that would be great to bring to the HEAL subcommittee. Folks at that table are involved in organizations at all different levels and are interested at the resident level all the way up to the policy level and have lots of different connections. Part of what's great about the consortium here is that we are a network and we can rely on one another and draw from each other's resources to move those things ahead. So Ann, I hope we'll be able to bring that up at one of our next meetings and talk about a strategy to address that.
Hello, Randy Siebel here. I lead Better Health Partnership, formerly known as Better Health Greater Cleveland, and I would like to, and I'm also at Metro Health, but I'd like to follow up with the same kind of question, I think primarily to Heidi and to Erica. how can we help you? I think we have probably 700 to 800 physicians, primary care, a lot of inner city, a lot of perimeter kinds of near-in suburbs and so forth. And if we had healthy eating, active living locations for patients who were seen, whether they were in the Neon setting in Huff or on the west side at Neighborhood Family Practice or Care Alliance or Metro Health or any of the sites, I think we could provide a distribution network to a lot of patients who need healthy eating, active living kinds of resources, and we're about to report on 170,000 people, patients with high blood pressure, diabetes, heart failure next week, and that just is the tip of the iceberg of the number of patients that the providers that are in Better Health take care of.
I'll go ahead and start. Thank you for that question. Although we've talked about each of our subcommittees specifically, I think it was alluded to earlier that there's a lot of intersection among all of them. And while we might not have spoken about those, there are absolutely natural intersections between healthy eating, active living, chronic disease management, and clinical and public health. And we are looking at how to do that. And I think you're absolutely right. If we can compile a resource of opportunities for healthy eating resources and active living resources, it absolutely makes sense to get it into hands of providers and figure out how to put that into systems so that it can be given to residents who could really utilize that information.
I think that my point was just going to be that we are working across committees and intentionally trying to make sure that we have people embedded in committees that can bring that cross-pollination we talked about earlier. And I can just say, as a clinician in the community, it would be hugely helpful for me to have that kind of a network and resource, because it's very hard in a very short time frame to figure out how to get patients what they need.
I just wanted to add one more thing. It takes folks like Dr. Sherry Boland who are willing to kind of tell folks like me, who's not a clinician, how clinics kind of function and how this could be done. So that's the great part of having this very transdisciplinary group involved, is that we're all thinking about things in different ways and trying to find new and innovative solutions.
I think we have time for one more question, and then, or do we need to?
I'd like 10 seconds if I can.
Okay.
Just to tell Randy also that I think what Better Health can do is help us link to the business community in a much broader way. I think that that's essential. And our friends associated with Better Health to link to the business community, because in the chamber, and I think that is a piece that is critical and you can help us with.
I guess I get the final word. Thanks. This is great. Jean Polster, Neighborhood Family Practice. I want to say, great gathering of community partners here. Congratulations on all your work. I'm all in. We can't say that enough today. I have a comment and a question. I think it's very brave for us to be talking about structural racism. I would encourage us to talk about poverty and race and ethnicity. When you look at some of the West Side indicators, we don't have the African American white divide. We have a lot of different races, ethnicities, Hispanic, historically, our Caucasian population that's lived in poverty. These are some structural poverty issues as well. My question, though, is when you look at some of the issues that poverty brings, my question really follows up on the previous two. In thinking about the West Side and some of the community assets, and these are the neighborhoods I'm familiar with, a lot of the access to healthy foods, the safe places to exercise and walk, and those things, there's not an investment in those neighborhoods. We're seeing gentrification, but on the other hand, we're seeing neighborhoods go down. And it's frustrating as a community health partner to look and see how can we make a carrot cost less than a hamburger. And I'm just wondering, when we look at how we as partners, I think a lot of the activity in terms of trying to bring access to communities around some of those issues has required a grant, or it's required a this or that, and so it's hard to take it to scale. And I'm wondering, when you look at neighborhoods and the opportunities to try to provide those opportunities for communities of poverty, whether or not there's some things that we can do together.
Thanks for your question, Jean. I think we've said throughout the morning that we really think that HIP-Cuyahoga is different. This is a different way to do business. And so I think as we think about these strategies and how we do this work, we're thinking about how do we leverage all the work and all the resources that we have so that we can make a bigger, broader impact. And specifically give attention to those neighborhoods that may not have the same kind of investment happening right now, and make sure that there's a voice for those folks to make sure that there is equity in the development that's happening across the city and across the county.
Just one last comment too, yeah, because I'm very familiar with the West Side, and those data are definitely aligned with what we see in some of our African American communities. So that one way to think about this is as we evolve strategies and tactics and activities that we want to use, we certainly could make those and adjust those so that they deal with the issues of poverty. Because when we talk about social determinants, we are talking about poverty, we are talking about employment, education, and those kind of things. So I don't see this as being kind of misaligned. I see it as aligned, but one of the 4 priorities that came up through the community health assessment was eliminating structural racism, and that's why we focused on that instead of all people.
So I think we have to wrap it up. I think this kind of roundtabling and sharing is exactly at the heart and soul of HIP-Cuyahoga, and they want to keep the conversation and the dialogue coming. So anybody who had a question or comment and didn't get to share it, you've got white cards. Please turn in the white cards. They have promised to put the question as well as an expert answer on the web so that we can have a continual dialogue. All the contact, if you want to tweet or Facebook or email, all the contact information is on the back of the plan. I'm going to turn it over to Terry for some closing remarks.
Thanks to everybody for being here today and for as Jean said, being all in with this approach. It's going to take the time, but I think the commitment to the core is what will be essential for us to change the trajectory. In terms of moving forward, on page 25, Martha would tell me to say that there's a moving to action section in the report. So I've done my duty there. In terms of cultivating partnerships, so you have lots of folks here, some are new. Get connected into this movement is what it really is, into the movement. We're going to build on the knowledge and capacity around health equity and doing that through our community engagement strategy that we're building with Common Health Action about how to take these messages out, how to talk about equity. And I think that's where, and to describe the inequities that exist in the same breath. We want to also understand that, in terms of the work we're doing on REACH, I see Barb here, the YMCA and Asia Inc. as well, Michael Bune and others are working on REACH programs. We need to align that work also with the existing HEAL work and work happening around chronic disease in the community to make sure that we are complementing each other and all the activity. We are going to be tracking our action plans very closely from our shared measurement and evaluation group, and we're going to be using the web and other networks to talk about progress. But we need feedback. It has to be a bi-directional process with the community, with the partners. And so we're counting on all of you to be part of that process going forward. But we see this as a new beginning, this new way of doing business. And I think that's what it's going to take for us to see those maps change and to do what all of us know needs to happen and what people deserve to, that everyone has the opportunity, deserves the right to be healthy. And it's time now to put those words into action.